Hello, everyone. Thank you for joining us for the May Healthy Transitions Colorado webinar. We're going to be talking about the patient activation measure and care transitions. My name is Kristen Paulson. I'm with the Center for Improving Value in Healthcare, and I'm really happy to be here with you today as we go through this presentation. So CIVIC is the managing partner for Healthy Transitions Colorado in collaboration with our partners CFMC, Colorado Hospital Association, the Colorado Healthcare Association, and the Colorado Rural Health Center. Healthy Transitions Colorado is a collaborative effort. We're focused on aligning and accelerating the existing efforts to improve transitions of care here in Colorado. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across specialties, facilities, and practices. Healthy Transitions Colorado coordinates the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. Our goals for this campaign follow the triple aim. Over 2 years, we hope to eliminate 8,700 readmissions, eliminate over 34,000 days in the hospital, and save over $80 million for Colorado. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take the pledge and learn more about what we do at Healthy Transitions Colorado, visit our website at healthytransitionscolorado.org, or you can email us at hello@healthytransitionscolorado.org. So just a couple of things before we get started. The phone lines have all been muted, and they will remain muted throughout the webinar. We're going to be using the chat feature available in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Questions posed to the presenter will be answered during the question and answer session after the presentation. This webinar is being recorded and will be posted to the Healthy Transitions website, so you can access this information again at any time without cost. I'm now going to turn the program over to Chris Delaney. He's the CEO of Insignia Health. Chris has spent many years working on patient-focused healthcare, and we are happy to have him join us today to tell us more about the PAM and care transitions. So if you hold on, I will unmute him, and he will take it away.
Thank you. I guess in the morning still for us in Portland, Oregon, and entering the back half of the day for the rest of you, I believe. Consider this kind of a starting point in dialogue around PAM if this is new for you, and by all means reach out to us and keep the dialogue going, including at the end of this presentation where we can field and address questions as well. So the patient activation measure, PAM as we call it, grew up in academia, grew up at the University of Oregon going back to 1999 as a starting point, and after about 5 years of development became an available tool in the marketplace in about the mid to latter part of 2004. The genesis for building PAM was this recognition by Dr. Hibbert and colleagues that increasingly measurement was going to be quite important to getting patients to take greater charge of their health and health care. And the ability to measure, this ability to self-manage or be involved in their care would allow us to identify and understand who needs more support. So how do we identify people that are low in activation, low in self-management ability relatively quickly? How do we, from that, then think about the tailoring of support? So if patients are at different ability levels, then we know that we need to focus on tailoring support to what they're capable of taking on. So not throwing everyone into the deep end of the pool with that 36-item checklist, expecting them all to engage in those behaviors. So how do you tailor support to what is realistic and achievable for an individual? And then finally, and this is really how PAM grew up initially, was as an outcome measure. And lots of research, you would measure at baseline, you measure again at 30 days or 60 days or 90 days. It depends on really the nature of the program, but you measure a second time and it gives you an outcome measure at the patient level, at the coach level, at the clinic level, at the population level. So are you indeed having an effect on a person's self-manageability or level of activation? So what we have today is an assessment that is 13 questions or 10 questions. So many of our clients use PAM 10. This survey takes about 3, 4, 5 minutes typically to complete by an individual. The survey is comprised of really declarative statements. And so we're not trying to catalog what people do or don't do. We're very much trying to avoid another health appraisal type survey, and instead wanting people to think about their health and ultimately help us capture a sense of their ability to self-manage or to be a self-manager of their health. So these declarative statements tackle three key domain areas: knowledge and skills, and then confidence, someone's emotional disposition. The survey is not about any one question. It's about how all 10 or 13 work together. And so when someone's gone through these questions and completed them, you get two really important metrics. One is an underlying score on a 100-point scale. So we use a method called Roche Analytics. Roche is the same math as behind the MCAT and the LSAT as examples. Highly sensitive, and when it works, and it did for Pam, it allows you to create a true interval level measure. What that means is people are measured on a 100-point scale where we know the value of a single point change in activation. It's like a ruler. Everything is equidistant, and it's a continuous variable. In other words, it goes up, and people can also go down on this 100-point scale. From the scale, we've been able to assign 4 cut points. So essentially, we start to see behaviors and outcomes shift empirically. And so you'll see 4 levels of activation along this 100-point scale. Most patients score between 30 and 80 in terms of raw score. PAM has been validated, and as of yesterday, a day before, about 140 peer-reviewed published articles, and that spans the globe. So about 22 translations exist so far of PAM. You'll see here on this slide, a visual representation of all the research that's been completed. It spans countries, but also a myriad of disease states, from HIV and hemophilia and Parkinson's to diabetes and heart disease, asthma, high cholesterol, disease prevention, and so on. From all this research, I always kind of jump to 2 important findings from this. One, demographics account for very little variation in PAM score. Quite often we think if we look at you, we know your age, your condition, your ethnicity, your income, your education level, we can form some kind of opinion as to your ability to take care of your health. We know that's really not the case, that many of these variables statistically are significant, but when you stack them all up and ask the question of how much change in PAM score is driven by these variables, it's only about 5 or 6%. The good news then is that most of what affects activation, we all can help change. We can help patients and individuals become more engaged in their health, whether they are rich, poor, any ethnicity, low income, high income. You're as likely to be a level 4 with a PhD as someone that is middle class income, guy out of high school. It could also be a level 4, and also could be a level 1. And so that's been a really important learning over the last decade. The second key learning is it's not about the disease state. So the disease state matters when we think about the intervention, but the things that drive self-management, the things that help raise activation, the things that lower activation are pretty much universal. I'll give you some examples in some slides of these kind of universal factors that really don't matter or depend on whether you're managing CHF or diabetes or asymptomatic high cholesterol. So from that completed survey, so you've taken those 10 questions. Typically, PAM is built into EMRs, care management software, or clients license our survey platform. But once you have that kind of vital sign, you have that 10-question survey completed, you have that underlying score, but we also have 4 levels of activation. So think about kind of patients at that lowest level. My doctor tells me I have heart disease. My doctor's in charge. They are typically 40% adherent to medications. They are frequent flyers to the ER. They are at very great risk, high risk of being readmitted post-discharge. Really, these people are quite struggling in their health. At the other end of the spectrum, at level 4, you've got patients that are very engaged. I am part of my healthcare team. My doctor can only do so much. I am my own advocate. They are compliant to self-monitoring. They're compliant to medications. They are doing a good job. As you might expect, people that tend to raise their hands in programs and come into programs are pretty activated. And we caution our clients around how do you use kind of expensive, often mediated support to support patients. Does that level 4 patient warrant an in-home visit post-discharge as opposed to a phone call, or perhaps just making sure they know where to call when they have questions, because they're not passive individuals. At the other end, though, a level 1 person, a level 2 person, great candidates for in-home visits, multiple in-home visits. A great candidate for that phone call home after a new medication is prescribed a few days later, just to make sure you understand what's going on, because they tend to be still pretty quiet and pretty passive in clinical encounters. And so you can start to think, before we even talk about tailoring support to an activation level, you can already start thinking about how you simply target resources more effectively, more judiciously, but also thinking about the folks that keep us up at night, and that is how to engage and how to move patients lower in activation. People in these lower two segments tend to account for about 30% of a commercial population, about 45 to 48% of a Medicare population, and 50 to 55% of a Medicaid population. So you can see there is an effect that lower income, well below the poverty line or extreme age, advanced age has as activation declines from commercial to Medicare to Medicaid. But again, it counts overall for not a ton of the variation, allowing us to really affect change with individuals. So I've mentioned a few times that underlying score. We use the 4 levels as kind of a way to operationalize the assessment. So what do we do differently based upon those 4 levels? I've seen segmentation models in healthcare and in other industries that have 12 components, 8 components, 16 components, completely and utterly impossible to operationalize in an environment that we're already treading water and dealing with lots of change, lots of innovation, lots of challenges. And so the 4 levels gives you a kind of a meaningful way to operationalize without overwhelming a coach or a clinician or a caregiver. But it's an underlying score that we particularly always want to keep our eye on. We had 2 studies published, many more unpublished, that have demonstrated the value of what happens when just one single point change in PAM score. So imagine somebody goes from a 50 to a 51. It takes about 10 or 12 points to cross levels for most individuals. But just a single point change is meaningful. So Kaiser Center for Health Research across their 9 states, which included Colorado, the study on the left with diabetes patients, they gathered PAM scores at the end of 2004. They didn't care so much about any intervention. They just wanted to watch and see what happens over the next 2 years. How predictive was that baseline PAM score? What they found was for just a 1 point higher PAM score, that associated to 2% lower hospitalization, a 2% improvement nearly in improved A1C control below 8%, and nearly a 3.5 point gain in having in the clinical record lab work. About a year and a half ago, an HIV study really mirrored those findings. Again, about a 2% roughly improvement in the behaviors and the outcomes of interest, looking at CD4 count, adherence, viral suppression. We've seen across many data sets kind of a golden rule forming that for the behavior, the outcome of interest, on average, you'd expect about a 2% improvement in that behavior outcome for a single point change in activation. So you may not move someone you're coaching 10 or 11 or 12 points, but even moving somebody 4 or 5 or 6 points is quite important. From the data we take in, so I mentioned all that worldwide research, we require de-identified data sharing, which allows us to learn about what it means to be in a level, and more importantly, how do we move people across this continuum. We create what we often call behavior maps. Here are 3 examples of how patients behave in 3 behavioral areas, one being exercise, another being medications as prescribed, another being preventive care, getting a mammogram. What you see here is a stair-step pattern that you see again and again and again. So imagine for heart disease, we've cataloged more than 200 motivators, behaviors, characteristics to activation levels. In this example, we're showing you just 3 for people managing chronic conditions, but it's that stair-step pattern over and over again. And how we use this is somewhat straightforward. So we know the guidelines that we want people to achieve. Software programs regurgitate these guidelines consistently. The challenge then is how do you get someone to a guideline behavior, whether it's clinical or a standard of care. We use this data to inform really where to start with somebody. So for instance, with medication taking, we know that levels 3 and 4, they're really approaching or near full adherence. At level 1, only a third of folks are taking medications exactly as prescribed. But we tend to find that it's about as good as behavior gets. So it tells us that we can start to be a bit more aggressive in supporting efforts to be fully compliant to medications at the lower 2 levels. When we look at exercise and a lot of lifestyle behaviors, there are somewhere between 15 and 20% compliant, which gives us caution. How do we then step further away from that guideline? So instead of, for instance, carb counting every day as perhaps prescribed, at level 1, what is a carb? How do you start to monitor carbs in a very simple sense? At level 3, we'd be going after that guideline of carb counting every day. Same thing with you think about the pillars of care transitions. Which items are most important and what are the initial steps, perhaps in the first few days, and how do you build upon that over time, as opposed to pushing these guideline behaviors for all, which data like this makes it very clear that 3s and 4s, we're not going to do any harm. But throwing these same guideline objectives at 1s and 2s can do great harm if we're not careful. A study published just a few months back, we've seen this in many other data sets, including QIO work prior to 2012. We've known for quite some time that the low activated account for a vast majority of readmissions. In this published piece of data from the Boston Medical Center, you'll see a hazard curve. Essentially, what's the risk of somebody being readmitted over the course of 30 days? The red bar are level 1, level 2 patients. The blue bar, level 3, level 4. So in this scenario, level 1s and 2s, the low activated are twice as likely to be readmitted post-discharge in this particular study. We've had other studies that have shown it to be about 80% of readmissions be 1s and 2s. We've had some studies show 100% of readmissions are 1s and 2s. So, it's very safe to say that the vast majority of readmissions come from patients that are lower in activation. We also know that patients lower in activation cost us a whole lot more just in a general sense. And so this is the Fairview system throughout Minnesota and parts of neighboring states that shows you a billed medical cost just related to the hospital costs only. And you'll see pretty clear delineation. The low activated are twice as expensive as the high activated. We've seen this replicated in a number of cost studies. And so where we're working today, we are supporting efforts really across the healthcare spectrum. Pharmaceutical firms, hospitals, health plans, community hospitals, health service firms, Medicaid agencies, safety net programs, commercial health plans, Medicare Advantage plans, readmission programs. We are working with hospitals and health systems in about 30 states. Accountable health, primary care redesign, readmissions, a variety of programs. State Medicaid. In fact, we just finished a license with the state of Colorado in a program supported by the Governors Association working with super utilizers in Medicaid. And so Pam will be integrated there. And Megan, who's joining me here today, is on that project. Go back one here real quick. We also have health plan clients, Medicare Advantage to commercial, so you'll see Rocky Mountain, Colorado Access on there, but also plans that have a presence that's strong in Colorado like WellPoint and United. And we've worked with CFMC for quite some time. In fact, CFMC and Dr. Jane Brock, largely responsible for PAM being included in the Affordable Care Act for Section 3026, which is preventing readmissions post-discharge. That has brought PAM to about, I can't remember the number of organizations, but in 40 states there are funded entities from the ACA 3026, and the potential reach of these projects is about 500,000 Medicare beneficiaries. So we see a lot of PAM use across the country, and I think CFMC is particularly close to seeing some of the best practice results from many of these groups that have now been using PAM for over a year. So let me switch gears and just give you a few examples of how PAM relates just to care transitions in particular. The first kind of example would be medication adherence. So this is a QIO. This is one of those projects that helps support PAM's inclusion in the ACA. So they had Work Scope 9, or Statement of Work 9. There were, I think, 14 QIOs working on readmissions, 3 of whom, Colorado, Bellingham, Washington, and Alabama, incorporated PAM into their work. We're also happy to say that the 3 top performers in evaluation were those same 3 QIOs. I'm not sure if it was just because of PAM, but doing many things well. in one of those QIOs, we have some data examples to share. And so this is from the Bellingham group. They looked at a number of pillar areas relative to PAM scores. So you'll see here first, filling meds and having meds and taking meds correctly post-discharge. So keep in mind this is one of the better performing QIOs. Despite that, you've got nearly half of patients at the lowest level without a fill. Right? This is a coach sitting across from you in your living room, counting pill bottles, counting pills, so about as good as reconciliation can get, and half the time a level 1 didn't have a fill. Now this drops considerably to the teens for level 3 and 4 individuals. You also find that when 1s and 2s don't have meds, they don't really realize it, or they didn't think it was a big deal to not have it. Level 3s and 4s, they found qualitatively, knew they didn't have it and felt that I don't need this medication. And so a very interesting change from the low to the high activated in explanations for when they are missing a medication. The same story holds for adherence. So taking what you have in your possession. You see non-adherence at nearly 60% for level 1, drops to 29% for level 4. And that same phenomenon is at work. 1s and 2s don't realize they're failing. 3s and 4s believe that they just may not need a medication or to take it in a manner that was prescribed. And so a very different mindset between the low and the high. Signs and symptoms. So being prepared, understanding your red flags, knowing how to respond to red flags. Here again, that stair-step pattern I showed you early on with the behavior map example in one of the first slide areas, here it is again. Level 1s are really almost half as likely to understand what their symptoms and signs are and then how to respond to them. But people and patients at the higher 2 levels, they know, right? Level 3 and 4, they're prepared, they understand. A drop off at level 2, bigger drop off at level 1. So again, it reminds us that those extra effort we put into place, the tailoring support that you deploy can make an enormous difference with patients lower in activation that struggle in care transitions. And then a final example, just thinking about active participation. So in an ideal world, we have a PAM score used with patient-focused education, but we also have clinicians, caregivers, coaches, clinical or non-clinical, that have PAM as a vital sign as well. And so that's the best of all worlds where it's in the EMR and people know what it means, but that the patient is being supported obviously in a level appropriate manner as well. Here you see in a national study looking at working with patients to set goals around diet, to set goals around nutrition, and to teach someone to self-monitor. So that latter goal particularly important in care transitions. And again, that old stair-step pattern. So half of level 1 patients felt like this is something they did with their clinician. Whereas at level 4 and level 3, heck yeah, 80% plus felt that this is something they did. We know clearly that the hydrated, it's just not about them, they're finding all the good docs and the good hospitals and the good programs. That's not the case. It's that they are part of the process. They're persistent when unclear. They're communicative. They're not passive. And they're prepared for taking an active role in their health. Whereas the low activated are much more likely to be quiet, to be passive, and to expect the system and their doctor to do it for them, which obviously we know that's a recipe for failure. So the purpose of showing those examples was to reiterate how the low activated struggle and how the high activated are much more accomplished and capable of taking an active and successful role in their health, but also to remind us that as we think about transitions of care, having a well-coordinated checklist of 4 pillars ultimately can be quite daunting for the low activated. And so how do you not only target your time, but begin to think about prioritization and what matters most over the first 2 days and the next 3 days and the next 3 days, which is perhaps more laborious, but can pay an enormous dividend with keeping patients that are low in activation from being readmitted. So let me talk a little bit about kind of our general approach to applying a PAM score. So getting that vital sign at baseline is obviously quite key. Ideally, PAM is incorporated into an EMR or into care management software, either fully or at least spaces to put a score on a level if a different tool is used to administer and manage the actual survey. The second step is often the easiest from applying a score, and that is just thinking about segmentation. Who gets an in-home visit? Who gets 2 in-home visits? Who gets an extra phone call? Who gets a phone call? Who gets more time? Who gets less time? It's the low activated as opposed to the high activated in this context. Step 3 is the process of tailoring support. Now we have the luxury, I guess, of many clients and many programs that have 6-month programs, 12-month programs, and so I recognize that in care transitions we're typically thinking about 30 days, 60 days, but even there we can gain a lot from tailoring, but it's just a bit more accelerated approach given the urgency of what's at stake. But there is the opportunity to tailor, and then finally reassessing. Are we having the effect that is intended and desired? One thing I wanted to share is just a little bit upon kind of what's kind of making people tick at lower versus higher levels. And we did a study where we wanted to understand the role of emotions and affect, and as well as the sense of being overwhelmed and the ability to set goals, near-term or long-term goals. So we used a Stanford emotion scale called the PANOS scale, and we created questions in those other 2 areas around goals and the sense of being overwhelmed. And then we created just average scores or factors across these sets of variables. And what you see here, the story that unfolds, is that the low activated are quite overwhelmed. The goal is to get through today, tomorrow. Their affect is as negative as positive. So they're in a really tough place to take in new information and to apply information. They are not problem solvers. And so, our skill development complexity shouldn't be complex, should be simple. The tone of empathy and understanding how they are struggling. That approach would be condescending, perhaps, and not so fruitful at the higher levels where these folks are not negative in affect, they are not consistently overwhelmed, and they are capable of setting and reaching goals. And so when we train coaches, when we build a brochure, a flyer, our eHealth platform, our mobile platform, all of these kinds of tools, we take to heart this understanding of someone's emotional disposition and ability to really problem solve and work with information that's provided. Are they goal-oriented or are they overwhelmed? Are they positive in affect or are they more negative in affect? And making sure that we work diligently to raise people to the point where they are looking like level 3s and level 4s. So, here's an example of a pillar checklist. Nicely choreographed, has the delivery side all aligned and the boxes have been checked. But for that comorbid CHF patient that's 70 years old, my count is you probably have 30 to 35 things that you might be expected to do in the next week following discharge. So I suspect you all at this point could pass the quiz of where's that level 1 person going to head with this checklist. They're going to struggle. They're going to struggle with weighing themselves at the right time, knowing how to respond to things, who to call. We know they struggle with making and keeping appointments. We know they'll struggle with their medications. And so how do we kind of parse this out? Which red flags are the reddest? Which yellow flags can come second? Which medications are quintessential? Which ones can wait on efforts until day 3, day 5, day 10? How do you prioritize these 30 or 40 things and know and help that person succeed in the next 3 days, 5 days with 4, 5, 6, 7 things? And recognizing that we don't have the luxury of building self-management over time, which is really ideal, that we have to intervene more, be involved more high touch, but we still need to think really hard about how much we're expecting someone to do that's low in activation. Our general approach is at level 1, recognizing that there are profound knowledge gaps. What is CHF? What do these medications do? Why do I have to take them? Becoming self-aware. What helps you manage your health? What gets in the way? Do you understand your role? And then small steps to build confidence, to kind of help the person learn, my gosh, I can do this. At level 2, we're closing knowledge gaps and really going after more clinically meaningful skills. At level 3, we expect skill pursuit at guideline objectives. They may not reach them all, especially around lifestyle, but we're not going to do any harm here. These individuals are capable of achieving many of these guidelines. And at level 4, I would argue these folks should not be in mediated programs for disease management or for case management quite often, or for care transitions, that they're good self-managers and that spending expensive resources here is not going to lead to much return. There are ways to support level 4 folks, helping them maintain their success, exceed guidelines, hit lifestyle type behavior guidelines, but they're pretty good at the blocking and tackling of a condition, if you will, medication taking, self-monitoring effectively, interacting well with clinicians, keeping appointments. Level 3s and 4s are pretty darn good with these important basics of a condition. I've mentioned many times around the importance of focusing upon the low activated. This is a set of our clients using our survey platform. And it ranges from Hopkins in the east to the state of Washington and Medicaid to a few other clients. And so we pulled data for 2012 and just looked at pre and post PAM. And what you find is first, on average, it was about 4 months between administrations. So that's a luxury that you won't have in a readmission context, but a common amount of time in disease management and other care management programs. But you'll see that the gains in activation are all among the low activated. 8 points of gain among level 1s. That's terrific. 9 points of gain among level 2s. Terrific. Level 3s, 3 points. Well, 3 points, we know that's worth about a 6, 7, 8% reduction in hospitalization. Not bad. We'll take it. But you definitely see a diminishing return. And then by level 4, essentially flat. Doesn't surprise us. These are activated people that have remained activated, but unless you're really working hard to push them into interesting, intriguing new heights, particularly around lifestyle areas, there's not going to be a lot of gain. And we know that there's also not much opportunity to reduce ER use or hospitalization because they're typically not using those resources. Two of the tools that we license to clients have been our effort to take a decade of research and find a way to apply it. So option 1 is we give our clients 4 binders of bar charts. Option 2 is that we create kind of a systematic way to share the evidence. And so that's the approach here. We focus on behavioral activation. So that is, what are the things to help a patient be a better self-manager? And so we're not trying to kind of replicate clinical guideline type software. It's really much more around coaching of self-management at the patient level. So this tool supports today about 8 or 9 disease states. So you'll see here diabetes, asthma, COPD, CHF, CAD. We also, in about a week, are launching schizophrenia, depression, renal failure, and substance abuse, in addition to the tabs you see here. Inside of this system, we focus upon key areas of self-management, so medication taking, condition knowledge, self-monitoring, nutrition, physical activity. And then we've laid out, as you see in the main body here, goals and steps that are in this area of self-management and appropriate for a level of activation. So it's not designed to be scripts, but more cues. So this is a nutrition example for a level 2 individual. I think it's managing diabetes. And so, we don't try to have every possible goal, but a really solid set of options, and as well as some good related action steps. And then in this particular product, we've cataloged a lot of CDC, NIH, and advocacy group resources that we've judged for level appropriateness and connected to goals and steps. So again, we call the overall model Coaching for Activation, and this is the online kind of expression of that model. Bringing this to life a bit more, so this is with diabetes patients, and it's comparing for you a level 1 and level 2. It's just showing you kind of goal options related to nutrition. And so if you kind of look at it, maybe a little hard to read, I'm going to have to squint here myself, but at level 1, you'll see kind of the language and the focus that's common for the low activated. Become aware, develop an understanding, become familiar, become aware, learn to use, start to grow, right? That's the language of getting you moving in the right direction, getting you started. At level 3, it's quite different. Develop a routine, improve habits, master use, get to the right, put it all together. We're pushing and helping people start to hit and even exceed, but probably hit is more likely, nutrition guidelines for diabetes at level 3. So hopefully this draws out for you kind of the contrast between low versus high in this area, looking at nutrition for diabetes. One of our clients in the western U.S., Peace Health, so hospitals and health clinics in 3 states, published a study, and we've used it quite a bit in presentations because it does a great job of bringing to life how in a clinical setting they use PAM. This slide shows how they're allocating resources. And so they took an assessment, their own assessment of health acuity and then activation level, and then thought about how do we get folks working at the top of their license based upon someone's level of activation and health status. You'll see here that if you were low activated and high acuity, top of the line credentials, MDRN. If you're a level 4, low acuity, no clinical support, so a care facilitator and recommendations for peer support groups. If you're a level 2, medium acuity, you got a wellness coordinator, which is non-clinical, nurse practitioner, and some RN time, so kind of a sharing of effort in the group there. The results of this program, and this was just one of the key ways they used PAM, they also used PAM in our coaching model to tailor support to activation levels. The impact of this program that they published was strong in many areas. In particular, you'll see in this graph the use of urgent care and the ER related to this primary care clinic in Eugene, Oregon. You'll see when the program began, there was a raw count of 71 ER urgent care visits across all day parts. The blue line is just looking at business hours, but focus on the orange line, 71 when the program began. By the end of the program, they were down by 38. If you look just over 12 months, so that's an 18-month time span, if you look just at July of 2009 versus July of 2007, you'd see a drop from 71 to 41. So they essentially cut use of the urgent care in the ER by almost half. They also were improving most clinical indicators, improved adherence. They published a number of positive findings over the course of this 18-month evaluation. So to kind of recap some of the highlights of PAM in preventing readmissions, first, I probably should have included in here, first is not to be taken lightly, but how is PAM integrated into your work? How does it affect patient flows? Who administers PAM? How does it get into the clinical record? All of these kind of core steps to get in place. But once that's accomplished, and happily we've done this in most states with many organizations, but once that's accomplished, the next step is typically just thinking about how you might target differently. In-home visits, appointment reminder strategies, follow-up visits, different ways just to simply use your current approach, but to allocate resources differently. Tailoring support. So how do you fight the urge to transition somebody with those 36 things and recognize that over the next 2 days you have to be really good at these 4 things, these 5 things, these 2 things, and then building from there. But you're going to build with more interactions because you've taken away some of those high-cost interactions from 3s and 4s, so you have the time, right? Potentially, you're going to be able to find that extra visit, those extra hour to really use that more effectively with level 1s and level 2s. And then finally, let's make sure we know we're having the effect intended, and that is the pre-post evaluation. So at discharge, prior to discharge, getting a baseline PAM score, and then at day 25, day 30, somewhere in there, working to get that second score to see how things are going from a self-management standpoint. So I know it's been a whirlwind tour, but happy to answer the questions that have come in through the course of this.
Great. Thank you so much, Chris. I really appreciate you taking the time to present to us on this. And we have had a few questions come in, but I'm going to give folks a few minutes to add some more questions to the list, and I'm going to take host prerogative here and ask you the first question. The PAM has become kind of a more and more visible thing over the past couple of years. Where do you see the area of greatest opportunity in the future for using the PAM to improve patient care?
Right, it's a great question. So, I think for us at Insignia, one pretty important opportunity is to help facilitate PAM into patient records. So right now, it's long IT lead times. It's sporadic. For us to be completely successful, I think we have to definitely be prepared to get PAM into kind of the EMRs, the Epics of the world. And it's been difficult to have it be done as an on-off at the Epic level. So, how do we help our clients be more successful at getting PAM into their work streams that are already sometimes backlog 6 months or 12 months. So I think that's kind of a logistical need, but I think pretty important. I also think we have seen many of our clients be quite successful, particularly in primary care programs that reduce readmissions and reduce ER visits and reduce urgent care. And then the program is stopped because on the fee-for-service side, it wasn't rocking their world, right? Reducing bed days, reducing revenue, and the ACO performance models, were perhaps not aggressive enough in sharing reward, or they weren't full reward models, or they just didn't plan for the impact. If you can reduce doc days, if you can reduce ER staffing, if you can shift beds, but all these strategically important things have to be thought through. So what happens when you actually use PAM? You are quite effective at raising activation. Use of hospital resources declines. Are you prepared for that from a fiscal and resource allocation standpoint in kind of the facility world? So that's been an interesting finding over the last 18 months in particular, that I don't think we had fully thought through helping clients think through that and plan for that. I guess one regard it's a great problem to have, but not a great problem if you're focused on, even as the nuns will say in hospitals, no margin, no mission. So how do you plan for that?
Great, thank you. So we've got some questions on the chat board here from Mary Lou. Where can people get a hold of the tool?
Right. So we license PAM, and you can just write us directly. You can write me directly. And we can handle that. You can also, for very small scale programs, license it online at insigniahealth.com. There's a online licensing tool. But those are really the two manners of kind of licensing PAM. And with a license, then you have access to PAM, parent PAM, caregiver PAM, and any of our, I think it's 22 translations, depending upon your population.
Great. Typically, who ends up administering this test?
So it definitely depends on your organization, but it does not have to be somebody clinical. So it can be an intake person, an administrative person that's been trained in administering the survey. You don't need to ask the questions unless your population suggests that would be the way to do it. So someone can take PAM on a piece of paper, on a kiosk, an email sent to home, on an iPad type device. So we tend to work with our clients to figure out what's the best device or mode of PAM completion, and do they need to read the questions, or is it just a simple kind of one-page form that's completed at bedside before discharge or with discharge. But the good news is the research has shown consistently there's no real mode effect, so any method will work and not bias results. And anyone can administer PAM, but there is training to be had that's really important. A lot of times people in these settings want to be helpers, and you can't help somebody complete the survey. And so there are right techniques and not so great techniques that we have to avoid just to make sure the survey is administered correctly if you're prepared in taking questions on the survey or asking the questions.
Great. From Kelly Galloway, has there been any research in the use of the PAM for pediatric, chronic, or complex conditions?
Yeah, great question. So in the pediatric setting, we're seeing more and more research and some great results with the parent PAM. So under the age of 13, we would want the parent PAM to be used, which essentially recognizes the parent as really the responsible party for that younger child. Teenagers, young adults do quite well at PAM, so the measurement properties hold up quite well for folks that are 15, 14, 16. So those individuals would just take kind of the regular PAM instrument. Great.
So it's coming from Gary Montrose. To what extent has the PAM been used or validated with different disability populations, such as people with cognitive or physical disabilities?
Yeah, so I haven't seen a whole lot of research with physical disabilities. We have PAM used in populations that have kind of mental health challenges, not necessarily cognitive impairment, but schizophrenia, MDD, bipolar, affective psychosis, and in all those categories, maybe surprisingly to me, PAM has held up perfectly well, just like any other disease state, which means that people that are struggling in these areas can find that ability to work through a 10-question survey. So some really good, great published research in the last year with schizophrenic populations that I'm happy to share if that's of interest. We have less data on real cognitively challenged populations, so in super advanced age, 80 plus, and early onset or dementia or Alzheimer's. But in those settings, typically we find it's known to the care providing team, and you would want to use the caregiver PAM. So not unlike the parent PAM, it'd be assessing that caregiver's ability to effectively support that individual. And it can be it's an informal caregiver or a formal caregiver, but typically like an informal caregiver, either a third-party organization or a spouse or a sibling, or a child. Often the eldest daughter is that caregiver.
Great. So the next two questions had to do with dementia and administering the PAM, and so I'm guessing that your previous answer would cover the dementia question?
It would, yeah. When dementia is at play, you definitely consider using the caregiver PAM in those environments or those settings that need.
Great. Well, it looks like we don't have any other questions about the PAM. Again, these slides and this recorded presentation are going to be available on the Healthy Transitions Colorado website at healthytransitionscolorado.org underneath our Education tab. Thank you again, Chris. If we don't have any other questions, I think we are going to just wrap up, and I'd like to thank you for taking the time to join us. And I hope it's been a valuable use of your time for everyone online, and that you've gained some information that you can use to further your care transitions efforts in your facilities. Again, thank you very much, and have a good day, everyone.
Thank you.